Hey everybody, this is the Module 3 Blue Button review. We're going to talk about airway, ventilation, and oxygenation. So first, quick anatomy review. So just remember, air can enter the body through two ways, right? The nostrils and the mouth. Travels into the pharynx or throat. Air traveling from the nose goes through the nasopharynx, and air entering the mouth travels through the oropharynx. Two passageways at the end of the pharynx, the trachea, and the esophagus. Obviously, we want the air going in the trachea and the food and drink going into the esophagus, right? There's a leaf-shaped cartilage type tissue. It's called the epiglottis that covers the larynx while food and drink is swallowed. Right? It's also pulled away from the opening to the larynx, which permits you breathing. All right, it's important to keep in mind that if the patient is unresponsive, the epiglottis might not be working, right? And the patient can be susceptible to foreign objects or vomit or blood, stuff like that in the airway that's going to enter the trachea, okay? That's why we got to suction and protect that airway on our unresponsive patients. Your larynx is your voice box. It contains the vocal cords. And then you have your thyroid cartilage or your Adam's apple. The cricoid cartilage is the most inferior portion of the larynx, and it is it's the only completely circular cartilage ring in the upper airway. All right, the lower airway begins at the trachea, right below the cricoid cartilage, and it ends at the alveoli all the way at the bottom of the lungs. There's little air sacs where gas exchange takes place. And the trachea, or the windpipe, as some people call it, is the passageway to the lungs. All right, it branches off, cuts off right there. The carina is that split, kind of like the fork in the road, right? And it goes into the left and right bronchi and then divides into smaller sections called bronchioles. The bronchioles end with millions of little tiny air sacs called the alveoli. All right, the lungs are surrounded by tissue called pleura. The visceral pleura is the innermost covering of the lung. The parietal pleura is thicker and it adheres to the inner portion of the chest wall. And in between them is what we call the pleural space, right? And it's got serous fluid. And that fluid works as a lubricant for those lungs to expand. Know the difference between ventilation and respiration, okay? So the mechanical process of you actually breathing in and out, okay, that's ventilation, right? That's what's creating pressure changes in the lungs. Okay, as you see on here, when you inhale, it's a negative pressure in the chest. And then when you exhale, it's a positive pressure. It's forcing that air out. Okay, inhalation is an active process. It requires energy. Okay, if you look on that picture that's labeled A, inhalation, if you look there, you see that the diaphragm is contracting and the intercostal muscles are contracting, okay? All those muscles are working there and that requires energy, okay? So that's an active process. On the other hand, the other picture B, exhalation is a passive process. That's when everything relaxes, okay? That does not require energy. Nothing's contracting here. The diaphragm is relaxing and the intercostal muscles are relaxing, and that way air is forced out, okay? Let's see what's next. All right, so your respiratory drive is controlled by your nervous system, all right, through the DRG and the VRG, all right, the dorsal respiratory group, ventral respiratory group, and the pneumotaxic center in your brainstem. All right, those are the respiratory centers that control the impulses that are being sent to your respiratory muscles, telling them to contract and relax, right? The chemoreceptors are continuously monitoring your O2 and CO2 and your pH levels in your blood. All right, and this is going to be important for people when we talk about hypoxic versus hypercarbic drive. So just keep that in mind. I think we talk about that on the next slide. But those chemoreceptors, right, they're there monitoring all the CO2 and O2 in your blood, right? They stimulate an increase or decrease in impulses from your respiratory centers to control the rate and depth of your ventilation, okay? I want you guys to understand that in a healthy person, right, the respiratory system responds mainly to changes in the carbon dioxide levels, okay? So if CO2 levels get too high in the blood, the chemoreceptors sense this, right? And they're going to send impulses to your respiratory muscles, making the patient breathe faster, right? So they can blow off more CO2. Okay, so normal, healthy people, like all of us, breathe on a hypercarbic drive. Okay, so understand that. Our breathing is to blow off CO2. That's why we're breathing. We're not breathing to suck up oxygen. We're breathing to blow off our high levels of CO2. That's a hypercarbic drive, okay? Now, when patients have something called COPD, chronic obstructive pulmonary disease, their CO2 levels are chronically elevated, okay? Their CO2 levels stay high, so eventually the chemoreceptors become insensitive, okay, to the changes in the CO2. They're used to it being super high, okay? So patients with the COPD, they depend on the chemoreceptors to recognize the low level of O2 to regulate their breathing, okay? Those are the guys and girls who are on a hypoxic drive. They're breathing to suck up the O2. They're breathing because their O2 levels are low, okay? They're not breathing to blow off the high CO2. They're breathing to increase their oxygen levels in their blood, okay? And that's, again, that's your patients with COPD. Okay, those are the people with emphysema and stuff like that from smoking for 50, 60 years. Okay, so how will you know if the patient is hypoxic, right? How do you know if they have low oxygen? Okay, on this slide, you look here and you'll see. All right, so signs of mild to moderate hypoxia: tachypnea, dyspnea, pale, cool, clammy skin. Right, and an early sign would be like agitation or anxiety. Okay, this is going to help you guys out and recognize some altered mental status things I'm about to tell you. So remember this: the brain constantly needs two things. Brain needs two things: oxygen and sugar. Oxygen and sugar. If you go without oxygen or sugar for long, those brain cells are going to start acting really weird, really, really quick. Okay, so if this patient is hypoxic, right, and they've been hypoxic just for a short while, they're going to be maybe anxious or agitated, okay, because they're low oxygen in those brain cells, right? Now you move on to the severe hypoxia, okay, instead of being pale, now they're going to be cyanotic. They're going to, be blue around the lips or the nail beds or the conjunctive in the eyes, all right? And then it moves to severe confusion and altered mental status to where they can be completely out of it. Okay, so if those brain cells don't have oxygen, they're going to be firing off, acting kind of funny. Okay. Here, okay, on this slide, we have in picture A, right? That's a picture of the alveolar and capillary gas exchange. All right, this occurs in the lungs. On the O2 hops from the lung onto the blood, and the CO2 hops off the blood into the lung and gets blown out through exhalation. Right? This is known as external respiration. That's the gas exchange that occurs in the lungs, is the external respiration. Now, B, okay, picture B, that's capillary and cell gas exchange, right? Same thing going on. Gas exchange is happening, except it's at the cellular level. All right, this is known as internal respiration. Okay, please know the difference. You're going to see that on the test: external versus internal respiration. Okay, remember, ventilation is the mechanical process of breathing, whereas respiration is the gas exchange. And then you have internal and external respiration, okay? These processes happen because of pulmonary ventilation, right? So if pulmonary ventilation gets disturbed, right, if the patient stops breathing, the patient can become hypoxic and eventually die if this is not corrected, all right? And several factors can cause interruptions in ventilation, okay? A brain injury, structural damage to the thorax, the chest injury, right? Increased airway resistance, like bronchoconstriction that you might see in an asthma attack, okay? Or airway patency, okay? Swelling or burns or a foreign body, somebody's choking, all right? All these things can mess up ventilation. If ventilation gets messed up, well, then this gas exchange is not going to occur, okay? Cool, let's move on. This is just a picture of the pediatric airway. What I want you guys to understand here is you're going to experience people say, oh, kids are no big deal. They're just little adults. No, they're not. Okay, they're much, much different. Okay, and look at this airway here. You can see that the airway is much different in a pediatric patient. Okay, the nose and the mouth is smaller. Okay, the trachea is more narrow. Okay, so if that trachea is more narrow, they're more susceptible to choking. And then kids are goofy, right? They put everything in their mouths. All right, so get that Lego out of there, right? And you're always saying that to the kids at home. Don't put that in your mouth. Get that out of there, right? They choke on everything. Okay, they're more susceptible to foreign body obstructions. Okay, and then look at the tongue. The tongue takes up more space in the mouth there. Okay, so very, very important. Protect these kids' airways. Okay, the number one cause of pediatric cardiac arrest is respiratory issues in children. Okay, think about it. Your 80, 90-year-old grandma, she's been eating cracklings and drinking and smoking her whole life, right? She lived her life. She did it big. Okay, it's time for her to go now at 80 or 90 years old. Her heart's probably going to give out. Okay, but this little guy here, his heart is probably fine unless he's born with some kind of weird congenital heart defect or something like that. Kids don't typically have heart attacks, right? The number one reason they go into cardiac arrest is because of airway and respiratory issues. All right, so keep that in mind when treating your pediatric patients. All right, so how do we assess if someone is breathing correctly or breathing adequately? All right, so what you're going to do is oscillate their lung sounds. There's a few different things we're going to do. First, we can oscillate, okay? And here you see the landmarks where you're going to put your stethoscope. And everybody should be doing this in class. Guys, listen to regular lung sounds, okay? Bother your family, bother your classmates. Listen to regular lung sounds so you know what regular lung sounds sound like. That way, when you have someone who is wheezing or they have crackles, rails, okay, when you hear something off, you know, hey, this doesn't sound normal, okay? So you're going to hear lung sounds. Auscultate y'all's, your people's lung sounds. Adequate breathing requires adequate rate and depth, okay? Adequate rate and depth. So they have to be breathing fast enough and they have to be breathing deep enough. If either one of those are messed up, we're gonna have to fix that, okay? And the way you fix it is with ventilations, okay, with the bag valve mask. All right, know these different rates here. The breaths per minute, it looks like it's a little bit messed up when we upload it here, but you can see normal for adult is 12 to 20 breaths per minute. Adolescents is 12 to 20. School age 18 to 25. Preschool is 20 to 28. Toddler 22 to 37. And then our neonates are 40 to 60 times a minute. Wow, they breathe really fast, right? So know these because you're probably going to see on the test, they might ask you, which one of these patients is tachypnic or bradypnic, and they'll give you all these different ones. So know your different rates, okay? And you're going to want to know how to fix that in case you see one of the, especially the little guys, like I just told you, they go into cardiac arrest because of respiratory issues. So if they have a respiratory issue because they're not breathing adequately, you want to fix that immediately, okay? All right, oxygenation. So big part of this exam and a part of your assessments and going further in your EMS career is knowing when to oxygenate versus when to ventilate, okay? And when do we ventilate? Look at that slide we just went over. If either one of those things are messed up, the rate and depth, we're gonna have to ventilate. So if they're breathing too slow or they're not breathing deep enough, you're gonna have to force air in there with that bag valve mask. You're gonna have to ventilate them, okay? Now, when a patient has adequate ventilation, right, if they're breathing deep enough and fast enough, but they're just having a little difficulty breathing, right, they just need to be oxygenated. They just need a little bit of help, right? So if the SpO2 is less than 94%, or they have signs of shock, which is like pale, cool, clammy skin, or they lost blood in a large amount, then we need to oxygenate these patients, okay? So the nasal cannula, right here at the top, let's see, your top left, the old lady with the floral pattern shirt there. That's a nice shirt there, Betty. That's a nasal cannula, and you can give them 1 to 6 liters per minute through the nasal cannula, okay? And that can deliver 22 to 44% of oxygen concentration, all right? Next, the other lady in the pink shirt there has a simple face mask on, okay? That can give 6 to 10 liters per minute and can deliver up to 60% oxygen. The non-rebreather mask that old man has right there with the plaid shirt, I like that plaid shirt, dude. The non-rebreather mask can hold 10 to 15 liters per minute and up to 60% oxygen. And then you get the Venturi mask with that little girl there. That's typically used for COPD patients because it can deliver a very specific O2 concentration. Okay, now why is that important, especially for your COPD patients? Okay, so remember, they are on that hypoxic drive. Their chemoreceptors are sensing, hey, we have a low O2, we need to suck up. That's why they're breathing, to suck up that oxygen, to get more oxygen in their blood. That's what their respiratory drive is based off of. Okay, so if we dump a whole bunch of oxygen on somebody who has COPD, their chemoreceptors see, hey, we're 100% oxygen, we're good, we can stop breathing now. So you can actually knock out their respiratory drive if they get over oxygenated. Okay, so that's why that Venturi mask is given to COPD patients, because it can deliver a very specific O2 concentration. All right, the two that we really carry in the field is that nasal cannula and the non-rebreather masks. Okay. All right. So supporting ventilation in your conscious patients. So you guys are going to see something that we have called CPAP, continuous positive airway pressure. That's one way that EMTs can support ventilation in a conscious patient. Okay. In order to get a CPAP mask, the patient has to be awake. That's kind of like a tag team thing. Like, they have to work with it. Okay. They can't be unresponsive with a CPAP on. Please don't do that. Okay. It's designed to continuously deliver positive pressure. Okay, and intended to inflate the collapsed alveoli. Okay, patients with COPD, asthma can benefit from this in the sense that the alveoli are remaining open. Okay, and there's less energy being used to breathe, so it relaxes the patient and it's blowing up those alveoli so they can have the best possible chance at that gas exchange. All right, so supporting ventilation in an unconscious patient. These are the guys who are out, they're unresponsive, right? First, you got to make sure they have an open airway. You got to open up that airway, okay? And there's two different ways we can open it, okay? So someone who does not have any kind of suspected trauma, like head, neck, spinal injury, you can do the head tilt chin lift, all right? And that's kind of hard to show in pictures. You guys should be doing this in class. But yeah, the head tilt chin lift is what happens when it's a patient without suspected spinal or neck injuries, okay? Now, the jaw thrust is for patients with that suspected head, neck, back trauma, okay? The patient with that trauma injury must have their head kept in a neutral inline position to prevent further injury or paralysis, okay? And that's the bottom picture. The bottom picture is the jaw thrust, whereas the top two pictures are the head tilt chin lift maneuver. All right, and then once you have their airway open, right, unconscious patients, you're going to start ventilating them. Okay, so unconscious patients cannot protect their own airway. Okay, so we have to use a device to help them. Okay, so we have the OPA or the NPA. The OPA is the oral pharyngeal airway, and then the NPA is the nasal pharyngeal airway. All right, the OPA is this top screen, the top picture. The old lady in the purple shirt there. She's got that yellow OPA going in there, okay? And at the bottom, the NPA for the man in the yellow shirt there, okay? Make sure that you are ventilating properly. You don't want to over ventilate with that bag valve mask, okay? I see a lot of people on their first calls, they're brand new and they get nervous and they're just squeezing that bag, squeeze, 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 okay? Don't do that, all right? Make sure you are ventilating whatever patient that you have at the proper rate, okay? So if you have that adult, you're gonna be breathing once every 5 to 6 seconds, okay? Think about it, you're overventilating. What's going on? You're causing all that extra pressure in the chest, okay? All kind of extra pressure in the chest. And what's that gonna do? It's gonna squeeze that heart, okay? If you're squeezing that heart, well, it's not gonna be able to fill up like it's supposed to, okay? So a patient who's in cardiac arrest, this is not allowing the heart to refill during CPR, okay? So yeah, don't do that. Make sure you are breathing for them properly. All right, so you see here on the screen, here's the OPAs. You're gonna make sure you measure and insert the correct size, okay? Obviously, if you had a neonate, you wouldn't use that yellow one, right? And if you had an adult, you wouldn't use that pink neonate one, right? Because that can block the airway. So make sure you're measuring it. You can measure it from the corner of the mouth to the earlobe there. All right, make sure you measure it. Now, if they have a gag reflex, they're not going to take that. Okay, so if they start to gag, get that out of their mouth. Okay, they're going to vomit, and now you have a whole nother problem. So get that out immediately. And something else you can use is the NPA. Okay, and that's how you measure the NPA from the nose to the earlobe again. Okay, make sure you're using the correct size. Also lubricate this. Okay, in our bags we have little packets of KY jelly. Make sure you're using that. You can cause some serious trauma to the inside of the nose. So please don't do that. Use that NPA if your patient has a gag reflex. Also, make sure the bevel, you guys are going to see the bevel, make sure it's towards the septum, and your instructors can show you what that means. Yeah, make sure the bevel is towards the septum. Next, you have suctioning here, okay? If they have that vomit, stuff in their airway, make sure you're suctioning, okay? Don't go too far, okay? Because you can stimulate the vagus nerve and cause them to become bradycardic, okay? If they get too bradycardic, they're going to go into cardiac arrest. So make sure you're measuring, okay? You don't go too far in. Suction on the way out, no more than 10 to 15 seconds, suction, and then start bagging again. Okay, make sure you are suctioning. Now, for your patients who cannot protect their airway and have a poor clinical outcome, okay, we're not going to be sitting there bagging them, with just an OPA or an NPA in the whole time. Okay, so we have advanced airways, okay, supraglottic airway devices. Okay, we have the King airway and we have the combi tube. And you guys should be familiar with these. Y'all should be practicing with these in class. Okay. There's two different ones, the King and combi tube. The combi tube we still teach, but it's kind of like a dinosaur. I know at Acadian we don't carry these. Some services do, but I know we do not. We use the King airway. All right, and we're going to kind of take a look at what these do. All right, so they have two cuffs on the King airway, right? They have the distal cuff and the proximal cuff, and you can see which each one does, right? So this is supposed to be inserted in the esophagus, right? So that distal cuff is going to inflate in the esophagus, right? So think about that. If any vomit or anything wants to come up, it's going to be blocked and it can't get into that trachea. That's awesome. And here on, in between, I can't use my arrow to show you guys, but in between those two bulbs, they have little holes where that oxygen is going to come out. It's going to go into that trachea and fill the lungs, okay? And then the proximal cuff inflates at the base of the tongue, right? And it's going to isolate the laryngopharynx from the oropharynx and the nasopharynx. All that oxygen you're pumping in there is going to go into the trachea. Okay, that's what you want. All right. This is for your patients who have a poor clinical outcome. You guys are going to learn further in the class with certain medical emergencies, some stuff can be reversed, like an opiate overdose, right? So, hopefully you don't have to use a King airway on someone who has an overdose. Hopefully you can just give them their Narcan medication and they wake up, and then now you have a live patient who is talking and breathing and protecting their own airway. Okay. Now, someone who has a poor clinical outcome, like they had a really bad trauma, they got ejected from the vehicle, or they're having a stroke and they can't protect their airway. We can't reverse that, right? They're not gonna just come to magically with us. And they might be vomiting or something like that, have blood. They might not be breathing, okay, because of a brain injury. Well, we have to fix that. We have to protect their airway and start breathing for them, okay? I suggest everyone, I always tell my class here in New Orleans, I suggest that everyone gets very, very, very familiar with these King airways, okay? We always talk about the ABCs, all right? Airways first, that's the most important thing, but also at Acadian, in our cardiac arrest scenarios in real life, when we have a cardiac arrest, the EMT is in control of this airway and dropping a King airway in within like the first 2 to 4 minutes of a cardiac arrest, while the paramedic is, doing IVs and medications and, potentially shocking the patient. You guys are going to be doing the airway and controlling the airway. So please be familiar with this. This is not something to just skip over and, oh yeah, I'll learn it later. No. You guys need to be really familiar with these King airways, okay? Now, the most advanced thing that we can do for an airway comes in the ALS side, right? the paramedics can intubate, endotracheal intubation. That's when we put a tube directly into the trachea, right? That's the best for the patient, but it requires time and skill, and sometimes it's really, really hard to do because of, the patient has a gigantic tongue, or they have all kind of vomit and stuff in their airway. That's why those King Airways are great. It's a blind insertion. It takes like 10 seconds maybe to get the whole thing ready to roll and drop it in. It's really, really foolproof and really, really easy to use. Okay, but for some reason, if you're working with a paramedic and they want to do an endotracheal intubation, okay, what you can do is assist them with cricoid pressure. Okay, so be familiar with the cricoid pressure. This is a maneuver that the EMTs can do with the insertion of the endotracheal tube. What you're doing is you're pressing down and doing the Burt maneuver, it's called. So backward, upward, rightward pressure, and you're holding that down and making the cords more visible and the landmarks more, easily seen for the paramedic to do a successful endotracheal intubation. So know about cricoid pressure and the Burt maneuver. You're probably going to see that on your exam. All right. And then let's talk about some special considerations. All right. So look at this guy. All right. That's called a stoma, right? A stoma is a surgical opening in the anterior of the neck. Okay. Often a tracheostomy tube is placed in the stoma. Okay. What you see on the right side of your screen, okay, that guy has a tracheostomy tube, a trach collar. The other man does not. He just has the opening there. Okay. A cause for the presence of a stoma would be like a laryngectomy, right? The patient's larynx is removed, usually due to cancer. Okay, can be because of some kind of an injury or something like that. Important thing to know is when ventilating this patient, okay, how are we going to ventilate them? All right, first of all, be sure you clear the stoma of any foreign matter. Sometimes they get phlegm and junk mixed up in there. You're going to have to suction that, clear that junk out of the way, right? If the patient has a stoma only, okay, if they don't have that tracheostomy tube or a trach collar, okay, use a pediatric mask to seal that opening. Okay, so you're going to use, if it's an adult patient, you're going to use an adult BVM mask with a adult BVM, I'm sorry, with a pediatric mask. Okay, and that pediatric mask is going to cover that tiny little hole, and you're going to breathe right through there. Okay, if the patient has a tracheostomy tube, like you see the patient with the black t-shirt there, you can hook up the BVM directly to the tube. Okay, you can just pop the mask off and hook it up right to the tube. It's adaptable. Okay, if the patient's chest doesn't rise, what do you want to do? All right, well, that air might still be coming out of the mouth and nose. So cover the mouth and nose while you bag. Okay, make sure all that oxygen that you're breathing in, that you're pushing down there, is actually getting to the lungs. Okay, so yeah, so that's that. Those are all the slides we have. The big important thing here in this chapter and with your assessment is knowing, hey, do I have to oxygenate this person or do I have to ventilate this person? Okay, if they're not breathing adequately, if the rate and depth is messed up, we have to fix that with the bag valve mask. Okay. Also, know the difference between hypercarbic and hypoxic drive. Very important. Okay. So good luck on your exam. I hope this helped. And yeah, have a wonderful, wonderful day.